তোমাদের আজকে ক্লাস রয়েছে অ্যান্টিকোলিনার্জিক্স উপরে। এর আগে দুটো ক্লাস কোলিনার্জিক ড্রাগসের উপরে হয়েছিল, তাই তো? তো বেসিক্যালি অ্যান্টিকোলিনার্জিক মানে কি বুঝি আমরা? আমরা জানি বেসিক্যালি অ্যাসিটাইল কোলিন কোন কোন রিসেপ্টরে কাজ করে? মাস্কারিনিক রিসেপ্টর, তাই তো, আর নিকোটিনিক রিসেপ্টর। By cholinergic drug, anticholinergic drugs, we mean specifically muscarinic receptor antagonist. Muscarinic receptor antagonist. They are also called parasympatholytics, as they are antagonizing parasympathetic nervous system. So they are also called parasympatholytics. নিকোটিনিক অ্যান্টাগনিস্টকে আমরা আলাদা টার্মে বলি। একটা বলি গ্যাংলিয়নিক ব্লকার্স which antagonize NN রিসেপ্টর। নিকোটিনিকে দুটো টাইপ আছে, সাব টাইপস রয়েছে, NN আর NM। NN-টা থাকে কোথায়? অটোনমিক গ্যাংলিয়াতে থাকে, অ্যাড্রিনাল মেডুলাতে থাকে। আর NM-টা কোথায় থাকে? নিউরোমাসকুলার জাংশন। গুড। সো বেসিক্যালি যেটা NN রিসেপ্টরকে ব্লক করছে তাকে বলি গ্যাংলিয়ন ব্লকার্স, আর যারা NM রিসেপ্টরকে ব্লক করছে বেসিক্যালি তাকে নিউরোমাসকুলার ব্লকার্স। নাও, so by anticholinergic drugs we are specifically meaning muscarinic receptor antagonist, and they are also called parasympatholytics. Now অ্যান্টিকোলিনার্জিক ড্রাগস এর অ্যাকশনটা বুঝতে গেলে আমাদেরকে কিন্তু আবার কোলিনার্জিক সিস্টেম কিভাবে কাজ করে, ফার্মাকোলজিক্যাল অ্যাকশন জানতে হবে। প্রত্যেকটা যেটা অ্যাকশন রয়েছে সেটাকে অ্যান্টাগোনাইজ করবে, মানে অ্যাকশনটা উল্টো হবে। লাইক হার্টের উপরে কোন রিসেপ্টর আছে? কোলিনার্জিক। হ্যাঁ, কোন রিসেপ্টর হার্টে আছে? সরি, M2। কি করে? ট্যাকিকার্ডিয়া করে। তো কি করবে অ্যান্টিকোলিনার্জিক ড্রাগ? ব্র্যাডিকার্ডিয়া করে। M2 উপরে গেলে ব্র্যাডিকার্ডিয়া করে। তো অ্যান্টিকোলিনার্জিক ড্রাগ কি করবে? ট্যাকিকার্ডিয়া। সো সিমিলারলি তোমার কোলিনার্জিক ড্রাগ M3 কোথায় কোথায় আছে? আইতে আছে, গ্ল্যান্ডে আছে, স্মুথ মাসলসে রয়েছে, তাই তো? স্মুথ মাসলে কোলিনার্জিক ড্রাগ কি করছে? কন্ট্রাকশন করছে। তো অ্যান্টিকোলিনার্জিক কি করবে? ডাইলেটেশন করবে। দ্যাট উইল রেজাল্ট ইন ব্রঙ্কোডাইলেটেশন। ব্লাড ভেসেলস এর উপর খুব কম অ্যাকশন আছে। দ্যাট উইল রিল্যাক্স বেসিক্যালি দি ইউরিনারি ব্লাডার মাসলস। সো এটা গেল স্মুথ মাসলের উপরে। আর গ্ল্যান্ডসের সিক্রিশনটা কি করে? M3টা বাড়িয়ে দেয়, এটা কমিয়ে দেবে। আচ্ছা, আর কোথায় আছে? M1টা কোথায় আছে? আইতে কি করে? হ্যাঁ, M3 আইতে কি করে? এটা হয়েছে ক্লাসটা। মিওসিস করে, তাই তো? তো অ্যান্টিকোলিনার্জিক ড্রাগ কি করবে? মিডরিয়াসিস করবে। সিমিলারলি ব্রেনে কোন রিসেপ্টর আছে? বা সরি, M1টা কোথায় আছে? স্টমাকে রয়েছে, ইন্টেস্টিনে আছে, আর ব্রেনে আছে, CNS এ আছে। CNS এ কোথায় আছে? এগুলো মনে রাখলে খুব সিম্পল রয়েছে বুঝতে গেলে। অ্যান্টিকোলিনার্জিক ড্রাগ CNS এ একটা রয়েছে বেসেল গ্যাংলিয়াতে। কি করে? ট্রেমা, রিজিডিটি, কোলিনার্জিক সিস্টেম। আর এটা কি করে? বেসিক্যালি ট্রেমারটা কমায়, বেসিক্যালি পার্কিনসোনিয়ান সিমটমসটা কমায়। সো অ্যান্টিকোলিনার্জিক আর ইউজ ফর অ্যাজ অ্যান অ্যান্টি পার্কিনসোনিয়ান ড্রাগ। আচ্ছা, বেসেল গ্যাংলিয়াতে দুটো সিস্টেম আছে, ডোপামিনার্জিক সিস্টেম, অ্যাসিটাইল কোলিনার্জিক সিস্টেম। যখন কোলিনার্জিক সিস্টেমটা বেড়ে যায়, দ্যাট রিজাল্টস ইন পার্কিনসোনিয়ান সিমটমস। এটা গেল। আর কোথায় আছে? ব্রেন স্টেমে আছে। হ্যাঁ, আচ্ছা, স্টমাকে কি করে? স্টমাক অ্যান্ড ইন্টেস্টিনে বেসিক্যালি, হ্যাঁ বল, এসিড সিক্রেশনটা বাড়িয়ে দেয়। কোলিনার্জিক ড্রাগ অ্যাসিডিটি কমায়, ইন্টেস্টিনাল মোটিলিটিটা কমায়। Now, coming to anticholinergic drugs or the muscarinic receptor antagonist or the atropinic drugs or the parasympatholytic drugs. These are the synonyms. Conventionally, anticholinergic drug is restricted to those which block the action of acetylcholine on the autonomic effectors and in the CNS exerted through muscarinic receptors M1, M2, M3. Though nicotinic receptor antagonists also block certain action of acetylcholine, they are generally referred to as ganglion blockers and neuromuscular blockers. The prototype drug in anticholinergic drug class is atropine. It's a basically comparative antagonist. It non-selectively inhibit or antagonize all the muscarinic receptor subtypes M1, M2, M3. So atropine is the prototype drug of this class, highly selective for muscarinic receptor, but some of its synthetic substitutes do possess significant nicotinic blocking property. We will come to it later. Now, the selective action of atropine can easily be demonstrated on a piece of guinea pig ileum, where acetylcholine induced intestinal basically contractions are blocked without affecting those evoked by histamine, serotonin or other spasmogens. The selectivity is however lost at very high doses. যখন guinea pig ileum experiment করা হয়, a part of ileum is taken in a medium and different spasmogens are added in the medium like acetylcholine, histamine. These are spasmogens. They contract the intestine. So what is seen when acetylcholine is added in the medium and when anticholinergic atropine is given, it inhibits acetylcholine induced contractions, but it is not inhibiting, atropine is not inhibiting action of other spasmogens like histamine, serotonin and others. So, it is more acetylcholine selective, muscarinic selective receptor antagonist. All anticholinergics are competitive antagonists. In addition, many drugs are there also there which have got significant anticholinergic property like we use tricyclic antidepressants in a patient of depression like basically amitriptyline, nortriptyline, these are used in depression. So, tricyclic antidepressants have got significant anticholinergic properties. Similarly, phenothiazines, it is used as an antipsychotic drug. They have got significant anticholinergic properties. Antihistaminics, particularly first generation H1 antihistaminic, they have got significant anticholinergic properties, and disopyramide possesses significant antimuscarinic properties. Now, the atropinic natural alkaloids are obtained in the plants of Solanaceae family. So, basically it is a plant product, atropine, hyoscine. The levoisomers are much more active than the dextroisomers. Atropine is a racemic while scopolamine is levohyoscine. Now, this is a classification of anticholinergic drugs. Number one is natural alkaloids that include atropine, hyoscine. Both of them are alkaloids obtained from the plant. Semisynthetic derivatives include atropine methonitrate, homatropine, hyoscine butyl bromide, ipratropium bromide, tiotropium bromide. Synthetic compounds, they include number one anti-secretory antispasmodics divided into two types, subtypes, quaternary compounds, tertiary amines. Quaternary compounds include propanthelene, oxyphenonium, clidinium, simetropium bromide, isopropamide, glycopyrrolate, and tertiary amines dicyclomine, valethamate, pyrangyepine. Mydriatics, They include cyclopentolate, tropicamide, vasoselective, that is more selective action on the urinary bladder, oxybutynine, flavoxate, tolterodine, darifenacin, solifenacin, and anti-Parkinsonian drugs including trihexyphenidyl, procyclidine, biperidine. Now coming to the pharmacological actions. The actions of atropine can be largely predicted from the knowledge of the parasympathetic response. Prominent effects are seen in those organs where the parasympathetic tone is higher. The organ which is more supplied by the parasympathetic nervous system will be affected more with the anticholinergic drugs compared to the organ which is more supplied by the sympathetic nervous system. Atropine blocks all subtypes of muscarinic receptors. Now coming to system one by one, central nervous system. Okay. So atropine has an overall central nervous system stimulating action. কোথায় কাজ করে? However, these effects are not appreciable at low dose because not that able to cross the blood-brain barrier, which produce only peripheral effects because of restricted entry into the brain. Hyoscine is another natural alkaloid which produces central effects even at low doses because it can readily cross the blood-brain barrier. Atropine stimulates many medullary centers because they are acting in the because of M1 receptor in the medullary centers, vagal, respiratory, vasomotor. It depresses the vestibular system, so it is also used in case of motion sickness, in morning sickness, and has anti-motion sickness property. Possibly the site of action of this drug is in the cholinergic link in the vestibular pathway, or it may be exerted at the cortical level. So medullary center এ কাজ করছে, excite করবে, second রয়েছে vestibular apparatus এ কাজ করছে, depress করবে, so it is used in anti-motion sickness. By blocking the anti-motion sickness মানে কি বোঝা যায়? লোকজন দেখবে গাড়িতে যাচ্ছে বমি করতে আরম্ভ করে বা মাথা ঘোরা কমপ্লেন করে, দ্যাট ইজ অ্যান্টি মোশন সিকনেস। ঠিক আছে, দ্যাট ইজ মোশন সিকনেস, সরি। আচ্ছা, বাই ব্লকিং দি রিলেটিভ কোলিনার্জিক ওভার অ্যাক্টিভিটি ইন বেসাল গ্যাংলিয়া, বেসাল গ্যাংলিয়াতে কোলিনার্জিক সিস্টেম আছে। নাও কি করে? ইট সাপ্রেসেস ট্রেমর অ্যান্ড রিজিডিটি অফ পার্কিনসনিজম। So anticholinergic drugs are used as an anti-Parkinsonian drug. High doses causes cortical excitation, restlessness, disorientation, hallucination and delirium, followed by respiratory depression and coma. Now coming to the heart, cardiovascular system. The prominent effect is tachycardia. Why does it is occurring? Because of blockade of M2 receptors on the SA node, through which the vagal tone decreases heart rate. Number 2, আচ্ছা, higher the existing vagal tone, more marked is the tachycardia. যতটা vagal tone বেশি থাকবে ততটা কাজটা বেশি হবে। It is maximum in the young adults, less in the children and in the elderly subjects. On intramuscular or subcutaneous injection, initial phase এ কিন্তু এটা tachycardia জায়গায় bradycardia করে। So there is a transient initial bradycardia with atropine on intramuscular and or subcutaneous injection. Why it is occurring? It is occurring because of blockade of M1 autoreceptors on the vagal nerve endings. Because of the action on the M1 autoreceptors on the vagal nerve endings, acetylcholine release is enhanced, and as a result, acetylcholine acting on the heart is causing transient initial bradycardia. Followed by কি হয়? atropine তারপরে M2 রিসেপ্টরকে ব্লক করছে on the SA node and causing tachycardia. This is suggested, this initial transient bradycardia is suggested by the finding that M1 antagonist pyrangiapine is the M1 selective antagonist, is equipotent to atropine in causing bradycardia. Moreover, atropine substitute which do not cross blood-brain barrier also produce initial bradycardia. তো এটা গেল এসএ নোড উপরে কাজ। আর কোথায় কাজ করে? অ্যান্টিকোলিনার্জিক অ্যাট্রোপিন এভি নোডের উপরে কাজ করে। কি করে বেসিক্যালি ইম্পালস ট্রান্সমিশন ফ্রম অ্যাট্রিয়া টু ভেন্ট্রিকল ওটাকে বাড়িয়ে দেয়, and as a result PR interval in the heart is shortened. So atropine abbreviates refractory period of AV node and facilitates AV conduction, especially if it has been suppressed by high vagal tone. PR interval is shortened. Coming to the blood pressure, not that significant effect because parasympathetic innervation is very sparse. Since cholinergic impulses are not involved in the maintenance of vascular tone, atropine does not have any consistent or marked effect on blood pressure. Tachycardia and vasomotor central stimulation tend to raise BP. Blood pressure is dependent on the heart rate and the cardiac output. So, as the tachycardia, it tends to raise blood pressure. Because of vasomotor central stimulation, blood pressure may raise. Again, histamine release and direct vasodilator action at high dose tend to lower blood pressure. Atropine blocks vasodipressor action of cholinergic agonist. Coming to the eye, we know the cholinergic drugs causes miosis, so atropine will cause mydriasis. Topical instillation of atropine causes mydriasis, abolition of light reflex and cycloplegia. Cycloplegia occurs because of basically relaxation of ciliary muscle. So what does cycloplegia means? Basically there is loss of accommodation. So typical instillation of atropine causes mydriasis, abolition of light reflex and cycloplegia that lasts 7 to 10 days. This results in photophobia and blurring of vision. The ciliary muscles somewhat recover earlier than the sphincter pupillae. Ciliary muscle is responsible for cycloplegia and sphincter pupillae is responsible for the mydriasis. The intraocular tension tends to rise, especially in narrow angle glaucoma. So atropine is contraindicated in narrow angle glaucoma patients because intraocular tension may rise. However, conventional systemic dose produce only minor ocular effects. So this is a schematic diagram. Is a normal eye. Basically, this is the iris having sphincter pupillae and the dilator pupillae, and this is a pupil. Okay. Now this basically dilator pupillae is supplied by the long ciliary nerve, which is sympathetic, and the basically sphincter pupillae, they are supplied by the short ciliary nerves, they are parasympathetic. Now what happens in case of basically mydriasis, there may be contraction of the dilator pupillae resulting in mydriasis, that is caused by alpha 1 adrenergic agonist because it is supplied by the alpha 1 receptor. Now it can also occur because of relaxation of the sphincter pupillae, that is caused by anticholinergic drug ganglion blockers. Now coming to the miosis occurs because of the contraction of the sphincter pupillae, as it is supplied by the basically cholinergic system. Muscarinic agonist can do, anticholinesterase can do, or it can occur due to relaxation of the dilator pupillae. As it is supplied by alpha 1 receptor, it occurs due to alpha 1 receptor antagonist. Coming to smooth muscles, all visceral smooth muscle basically M3 receptor the supplied রয়েছে. So all visceral smooth muscles that receive parasympathetic motor innervation are relaxed by atropine because of M3 blockade. So what happens? Tone and amplitude of contraction of stomach and intestine are reduced. So there may be constipation and the intestinal spasm may be relieved, but little effect on the peristalsis. Why? Because that is more dependent on the local reflexes of the enteric nervous system, that is also dependent on the other neurotransmitters. So because it is primarily regulated by local reflexes and other neurotransmitters. Enhanced motility due to injected cholinergic drug is more completely antagonized than that of vagal stimulation. Why? Because in case of vagal stimulation, Other than acetylcholine, other neurotransmitters are also released like VIP. And basically when we are injecting the cholinergic drugs, the action is only through the acetylcholine. So anticholinergic drugs more completely antagonize the enhanced motility due to the injected cholinergic drugs. On the bronchial smooth muscle, it is causing bronchodilation and they reduces airway resistance. So they are especially in the COPD patients and asthma patients. What happens? Inflammatory mediators that are released particularly in asthma patients, histamine, prostaglandin, leukotrienes and kinins, they exert bronchoconstriction via basically increased vagal activity in the bronchial smooth muscles and by the direct stimulant action on the bronchial smooth muscle and glands. Atropine attenuates their action by antagonizing the reflex vagal component. যে ইনফ্ল্যামেটরি মেডিয়েটার্স গুলো ব্রঙ্কিয়াল অ্যাসমাসে রিলিজ হয় সেগুলো ব্রঙ্কো কনস্ট্রিকশন করে বাই এনহ্যান্সড ভেগাল অ্যাক্টিভিটি অ্যান্ড বাই ডাইরেক্ট এফেক্ট অন দি ব্রঙ্কিয়াল স্মুথ মাসল. So basically antimuscarinic drugs, they block the vagal component and are causing bronchodilation. Atropine has got relaxant effect on the ureter and urinary bladder. So what can occur? Urinary retention can occur, is the side effect. Urinary retention can occur in older males, particularly with prostatic hypertrophy. Those are more prone to urinary retention. Now, however, this relaxant action can be beneficial for increasing bladder capacity and controlling detrusor hyperreflexia in neurogenic bladder. Like in case of elderly patient, what happens? Many of them have got urge incontinence. একটু ইউরিনটা ফিল হলেই কিন্তু আর্জটা পায় ইউরিনটা করার জন্য. In those case patients, basically by increasing the bladder capacity, the patient can be made symptomatically better. So they are helpful for basically increasing bladder capacity and controlling detrusor hyperreflexia in neurogenic bladder, enuresis. বাচ্চাদের বেসিক্যালি রাত্রিবেলা ইউরিনটা পাস করার সমস্যা থাকে, ইনইউরেসিস বলি আমরা, নকটার্নাল ইনইউরেসিস. In those cases also it can be helpful. Relaxation of biliary tract is less marked and effect on uterus is minimal. Coming to the glands, atropine markedly decrease sweat, salivary, tracheobronchial and lacrimal secretion because of M3 blockade. Skin becomes dry, eye becomes dry because of dryness of mouth, talking and swallowing may be difficult. Atropine decreases secretion of acid, pepsin and mucus in the stomach, M1 receptor blockade. But the primary action is on the volume of secretion and so that the pH of gastric content may not be elevated that much. Since bicarbonate secretion is also reduced, rise in pH of fasting gastric juice is only modest. It is for this reason basically relatively higher dose are needed and atropine is less efficacious. এখন পেপটিক অ্যালসার পেশেন্টের ট্রিট করতে গেলে H2 blockers, protein pump inhibitors, এটা পড়া হবে পরে. These are the drug of choice, not anticholinergic drugs because higher dose are needed, more side effects. And pancreatic secretions are not significantly reduced. Bile production is not under cholinergic control, so not affected. Body temperature. Anticholinergic কি করে? Basically sweat secretion decrease করে দেয়. So that can lead to rise in body temperature. Again, hypothalamus temperature regulating center আছে. Because of action on the temperature regulating center in the hypothalamus, the body temperature may rise. Children are highly susceptible to atropine fever. Local anesthetic, atropine has a mild anesthetic action on the cornea. Now, the sensitivity of different organs and tissues to atropine varies. It's not that it will be uniformly affecting the stomach and the eye and the muscles and glands. No. The sensitivity of different organs and tissues varies because of different vagal tone or different parasympathetic tone in different organs and can be graded as saliva, sweat, bronchial secretion are most affected compared to eye, bronchial muscles and heart, and smooth muscle of intestine and bladder are less affected and least effect on the gastric gland and smooth muscles. Atropine more effectively block responses to exogenously administered cholinergic drugs than those to parasympathetic nerve activity already discussed করেছি আমরা. Now coming to difference between the atropine and the hyoscine. আমরা mostly atropine পড়েছি, subtle difference দেখে নিই. The source of atropine is Atropa belladonna and Datura stramonium. For hyoscine it's Hyoscine niger. The base is tropine and here it is scopine. On the CNS effect, mostly the effect of atropine is excitatory and it does not affect the brain or the CNS at low doses. It affects at high dose because it does not clear the blood-brain barrier so readily. Hyoscine on the other end, it has got more depressant effect. Only at very high dose it shows excitatory effect and it can show CNS effect even at low doses because it readily crosses blood-brain barrier. Anticholinergic property more potent on the heart, bronchial muscle and intestine, while hyoscine is more potent on the eye and secretory glands. Duration of action, atropine is longer, for hyoscine is shorter. Anti-motion sickness property more with the hyoscine. Pharmacokinetics, both atropine and hyoscine, they are rapidly absorbed from the gastrointestinal tract. They apply to the eyes, they freely penetrate the cornea. Passage across the blood-brain barrier is somewhat restricted for atropine. Hyoscine has better blood-brain barrier penetration. About 50% of the atropine is metabolized, while hyoscine is more completely metabolized. Plasma half-life 3 to 4 hours. Coming to atropine substitutes. Now we know atropine is uniformly affecting all the M1, M2, M3 receptors or blocking M1, M2, M3 receptors. Now if we want more selective action to particular organ, so what we require basically more selective antagonist. So for getting those effects, different atropine substitutes had been prepared, semisynthetic or synthetic. So many semisynthetic derivatives of belladonna alkaloids and a large number of synthetic compounds have been introduced with the aim of producing more selective action on certain functions. Most of these differ only marginally from natural alkaloids, but some appear promising. Now, when we are discussing atropine substitutes, number one, quaternary compounds. What do we mean by quaternary compounds? Basically, they have got quaternary ammonium ion in their structure. So, what the benefit? So, what can be the pharmacokinetic properties of this type of compounds? As they have got ammonium ion, polar, they are polar in nature. So, polar hole ki hobe? Absorption ta delayed hobe, absorption hobe na bhalo, তাই তো? Elimination ta তাড়াতাড়ি হবে না. So absorption, delayed absorption will be there and the action will last longer. It will not be able to cross the blood-brain barrier, so central effect will not be seen. It will not be able to penetrate the eye. Incomplete oral absorption, poor penetration in the brain and eye. Central and ocular effects are not seen after parenteral or oral administration. Elimination is generally slower. Majority are longer acting than atropine. They have got additional, quaternary compounds have got additional higher nicotinic blocking property. Because of this, postural hypotension and impotence because of decrease in ejaculation and impotence are occur as an additional side effect with these compounds. At high doses, some degree of neuromuscular blockade may be seen. So these are the quaternary compounds available: hyoscine butyl bromide, atropine methonitrate, ipratropium bromide, very important, tiotropium bromide, propanthelin, oxyphenonium, clydinium, simetropium bromide, isopropamide, glycopyrrolate. Hyoscine butyl bromide, they are less potent, longer acting, because they are quaternary compounds used in esophageal and gastrointestinal spastic conditions. Just for that. Atropine methonitrate used for abdominal colics and hyperacidity. Ipratropium bromide. Ipratropium bromide is used for bronchodilation. They are more selective for bronchial smooth muscles. Okay. So it acts selectively on the bronchial muscle without altering volume of secretion, respiratory secretion or consistency of respiratory secretion. Additional advantage, they do not affect mucociliary clearance. So the chance of respiratory infection will be lower. Another desirable feature is that in contrast to atropine, it does not depress mucociliary clearance by bronchial epithelium. Now, as they are quaternary compound, it has gradual onset of action, late peak at 40 to 60 minutes of bronchodilator effect in comparison to inhaled sympathomimetics. আমরা দেখব তোমাদের হয়েছে এখন হয়নি অ্যাড্রেনালিন তো হয়েছে তোমাদের ইনহেলড সিম্প্যাথোমাইমেটিক্স কি আছে বিটা 2 অ্যাগনিস্ট কি আছে পড়া হয়েছে তো তোমাদের অ্যাড্রেনালিন ড্রাগস হলো তো বিটা 2 অ্যাগনিস্ট মধ্যে রয়েছে শর্ট অ্যাক্টিং লং অ্যাক্টিং শর্ট অ্যাক্টিং স্যালবুটামল হ্যাঁ terbutalin long acting formoterol salmeterol they act instantaneously and is used for immediate effect in a patient with bronchoconstriction. Ekta patient basically acute exacerbation of COPD by asthma niye esche, the drug of choice basically inhaled beta 2 sympathomimetics. ঠিক আছে now so thus it is more suitable for regular prophylactic use, not for immediate relief, because their action is slower and rather than rapid symptomatic relief during an attack. Action lasts 4 to 6 hours. Now, when we see the bronchial basically tree, the anticholinergic receptors, cholinergic receptors, they are more on the larger central airways, and the adrenergic receptors are more, or the beta 2 receptors are more on the peripheral bronchioles. So, ipratropium bromide, it acts on receptors located mainly in the larger central airways. The parasympathetic tone is a major reversible factor in COPD than in bronchial asthma. The drug of choice in a patient of COPD is not sympathomimetic. It is anticholinergic. While the drug of choice in bronchial asthma patient is sympathomimetic, not inhaled corticosteroid better. The drug of choice in asthma patient is inhaled corticosteroid, not anticholinergic. Why? Because in COPD patient the major reversible factor is the parasympathetic tone, and by reversing it we may give symptomatic relief to a patient of COPD patient. Now, in asthma, the major problem is inflammation. So, inhaled corticosteroid is the drug of choice there. The parasympathetic tone is the major reversible factor in COPD than in bronchial asthma. Transient local side effects like drying of the mouth, scratching sensation in trachea, cough, bad taste, nervousness are reported in 20 to 30% of patients, but systemic effects are rare because of poor absorption from lungs and GIT. Again, quaternary compound, so poorly absorbed. Tiotropium bromide, it's again used as an inhaled anticholinergic drug in a patient of obstructive airway disease like COPD asthma. It's longer congener of ipratropium bromide, it's more longer acting. So, a new congener of ipratropium bromide which binds very tightly to the bronchial M1 M3 muscarinic receptors, producing long lasting bronchodilation. Effect lasts for around 24 hours. Binding to M2 receptor is less tight, conferring relative M1 M3 selectivity. Like ipratropium, it is not absorbed from respiratory and GI mucosa and has exhibited high bronchial selectivity of action. Propanthelin, it is used for peptic ulcer patients and in gastritis. Use has declined because of the addition of H2 blockers and the proton pump inhibitors. Drug of choice in peptic ulcer patient is proton pump inhibitors. Oxyphenonium. Oxyphenonium is similar to propanthelin, used for peptic ulcer and in patients of gastrointestinal hypermotility. So এগুলো drug design করা হয়েছে for specific action in specific organ. Simetropium bromide is again a quaternary ammonium anticholinergic antispasmodic drug, especially promoted in patients of irritable bowel syndrome. Okay, what does they cause? They cause relief in abdominal pain and loose motion. Dryness of mouth is the commonest side effect. Isopropamide, they are indicated in hyperacidity, nervous dyspepsia, irritable bowel syndrome and other gastrointestinal problem, particularly related to the emotional and mental disorders. Glycopyrrolate. Glycopyrrolate basically, for what they are used, they basically decrease the respiratory secretion volume. So they are particularly used for pre-anesthetic medication and during anesthesia. Potent and rapidly acting antimuscarinic drug lacking side effects. It poorly crosses blood-brain barrier, so central side effects is lower. So they are more preferred in as a pre-anesthetic medication. Tertiary amines. Now, in contrast to the quaternary compounds, tertiary amines, they are not polar, so they can be readily absorbed. Drugs are dicyclomine, valethamate, pyrangyepine. Dicyclomine, it has a direct smooth muscle relaxant action, and in addition to weak and somewhat M1 selective anticholinergic action, they are preferred as an antispasmodic in case of intestinal colic. So it exerts antispasmodic action at doses which produce few atropinic side effects. Not recommended in infants below 6 months of age because they are more prone to atropinic side effects. It has antiemetic property, also used in morning sickness and motion sickness. Morning sickness mane hoche a pregnant mother in early pregnancy, they have got nauseating tendency in the early morning, and that is morning sickness. So it has also antiemetic property, has been used in morning sickness and motion sickness. Dysmenorrhea and irritable bowel are other indications. Dysmenorrhea mane painful menstruation. So painful menstruation, enough painful to affect the daily life. কিছুটা পেন নরমালি থাকে, যদি পেনটা অতটা বেশি কি ডেইলি লাইফ অ্যাক্টিভিটিস কে এফেক্ট করে, that is abnormal and that is called dysmenorrhea. So dysmenorrhea and irritable bowel are other indications. Valethamate, primary indication to hasten dilatation of cervix, so useful in case of delayed labor. Also used as visceral antispasmodic for urinary, biliary and intestinal colic. Pyrangyepine is a selective M1 receptor antagonist, inhibit gastric secretion without producing typical atropinic side effects. Indicated in peptic ulcer patient. Use has declined because of advent of H2 blockers and proton pump inhibitors. Now, vesicoselective anticholinergic, more commonly used. Their action is more on the urinary bladder, and they are useful in patient of prostatic hypertrophy patients. They are useful in patients of overactive bladder, or neurogenic bladder. The drugs are oxybutynine, tolterodine, flavoxate, darifenacin, solifenacin. Oxybutynine, they are relatively selective for M3, M1 subtype. Because of vesicoselective action, it is used in patients of detrusor instability, resulting in urinary frequency and urge incontinence. Beneficial effects have been demonstrated in post-prostatectomy vesical spasm, neurogenic bladder, spina bifida and nocturnal enuresis. Oxybutynine, again similar to anticholinergic side effects are common after oral dosing, but well, they are showing anticholinergic side effects. So what is done? Basically intravesical instillation of oxybutylene, they produce lesser atropinic side effects and improves the bladder capacity. Oxybutylene is metabolized by CYP3A4, so the drug dose should be decreased in patients taking CYP3A4 inhibitors. Like CYP3A4 inhibitors কি আছে? Example পড়তে হবে, very important topics even in MCQs in the NEET exam. Erythromycin, ketoconazole, Tolterodine is natively M3 selective muscarinic antagonist having preferential action on the urinary bladder, less likely to cause dryness of mouth and other cholinergic anticholinergic side effects. It is indicated in overactive bladder with urinary frequency and urgency. Metabolized by CYP3A4, the dose should be reduced in patients taking CYP3A4 inhibitors. Flavoxate, basically similar to oxybutylene, it is used in patients having urinary symptoms associated with lower urinary tract infection. Darifenacin, relatively M3 selective antimuscarinic with preferential action on bladder muscles, indicated in urinary incontinence, urgency and frequency. Solifenacin, similar to darifenacin, no clinically significant difference between the two has been observed. Drotaverine. Drotaverine is not an anticholinergic, but it is used as an antispasmodic in the intestinal colic. Now, how does it act? It is basically acting on the PDE4 receptor, phosphodiesterase subtype 4 receptor. Phosphodiesterase কি করে? Receptor কি করে? Actionটা কিভাবে করে? Basically, they decrease the cyclic nucleotides. So, it is a non-anticholinergic smooth muscle antispasmodic inhibiting PDE4 selective for smooth muscle. As a result, there is elevation of intracellular CMP or CGMP causing smooth muscle relaxation. It has been used orally as well as parenterally in intestinal, biliary and renal colics, IBS, uterine spasms, etc. without anticholinergic side effects, which is seen with dicyclomine, that is anticholinergic. Adverse effects reported are headache, dizziness, constipation and flushing. Fall in BP can occur on IV injection. Mydriatics. Mydriatics মানে dilatation of pupil. Atropine বললাম কি atropine mydriasis করে, but the problem is that it's very long acting. The mydriasis and cycloplegic effect last for 7 to 10 days. So a patient has come for eye examination. So তাতে কি করতে হবে? mydriasis করতে হবে because of proper examination of the retina and the fundus. So if we give a drug which is having a 7 to 10 day effect, that is not practical. So atropine is lesser used, is not used practically in a patient with when comes for refractory eye testing for basically fundoscopy. So atropine is a potent mydriatic, but it is slow and longer acting, undesirable for refraction testing. Though the pupil dilates in 30 to 40 minutes, cycloplegia takes 1 to 3 hours. The subject is usually handicapped for about a week. Atropine substitutes attempt to overcome these difficulties. However, atropine itself is used in iridocyclitis and keratitis, which is the drug of choice. Coming to the mydriatics that are used, homatropine, cyclopentolate and tropicamide, particularly cyclopentolate and tropicamide are used. Coming to homatropine, it is 10 times less potent than atropine. Instilled in the eye, it acts in 45 to 60 minutes. Mydriasis lasts 1 to 3 days, while accommodation recovers in 1 to 2 days. It often produces unsatisfactory cycloplegia in children. Why? Because in children the ciliary tone is very high. So, higher dose is needed for cycloplegic action. Coming to cyclopentolate, potent and rapidly acting, mydriasis and cycloplegia occur in 30 to 60 minutes and last about a day, comparatively practical. It is preferred for cycloplegic refraction, but children may show transient behavioral abnormality. Why? Because when they are applied in the eye, they pass through the nasolacrimal duct, absorb from the nasal mucosa, cross the blood-brain barrier and may show basically transient behavioral abnormalities. So, but children may show transient behavioral abnormalities due to absorption of the drug after passing into the nasolacrimal duct. It is also used in iritis and uveitis. Tropicamide is the quickest 20 to 40 minutes and briefest action 3 to 6 hours, but it is relatively unreliable cycloplegic. So, not that beneficial in children, but they are satisfactory for refraction testing in adults and as a short acting mydriatic for fundoscopy. The mydriatic action can be augmented by addition or combination with phenylephrine. It is an alpha agonist.